thanks for the opportunity to present our work. This is a very interesting endeavor, actually. I'm looking forward to many interesting discussions. I would like to present quickly the range of activities that we do to move from the generation and processing of medical images to generation of digital twins and analysis of how those can be helpful in the clinical workflow. You may be familiar with Siemens Healthineers. We are a large engineering company. We have been working on technology solutions that help across the clinical workflow, be it on generation of medical images, laboratory diagnostic, point-of-care testing, support for interventional procedures. One of the relevant things, I think interesting thing, is that through our technology, of course, we touch a large number of patients, and the technologies that we develop are actually involved in clinical decisions, and many of them, and across the spectrum of the clinical decisions. So this all, of course, means that we get exposed to how the clinical workflow is designed and potentially how we can design solutions to improve it, hopefully. Imaging, medical imaging, of course, is one of the main core businesses, and this is just to say that, of course, data generation and the quality of the data that we generate is one of the focus of our technology development and innovation. So on the left, you see one of the earliest images, MRI images of a brain, of the skull of a subject. In last century, and this is pretty much where we are today with 7 Tesla MRI diffusion tensor imaging to the application of tractography in the brain. Just to say that this is one of the directions that we are exploring, how to further push the limits of medical imaging. And one other aspect, it's not the only one, but another aspect is fruition of medical images. So that's another example. So once you have highly detailed images of the subject of interest, of the tissue or the organs, you can work also on the rendering side. So this is a technology that we introduced. We call it cinematic rendering. It's based on advanced scattering, advanced light scattering models to generate photorealistic images. And one of the use of these is, of course, that hopefully disease and pathologies may be more conspicuous, more evident, easier to be read. And another case could be outreach, patient communication, and potentially also teaching opportunities. A lot of what we do is, of course, based on machine learning, because, as you know, this is nothing new, but machine learning has been a key technology for data processing, showing great benefits for the topics of image processing, computer vision in general. And now the revival of deep learning architectures brought to the front stage also the importance of large training set, what we call big data sometimes, which means essentially that new learning architectures are actually capable of extracting more complex patterns from the input and correlate them with the output, with the labels, with higher accuracy as you increase the size of the training set. Much better than what's done in traditional machine learning. So this brings some of the challenges: access to data, access to labels, and computing power to process the training. There is another dimension to this, essentially. So when we talk about big data, what data are we talking about? How are they used? So it's also interesting to structure the discussion based on the consumption of the data. And you see at the very basic level, at the data generation level, at the level of the scanner, some of the challenges that you can try to solve are: how easy is it to generate? How can I use learning techniques, or how can I use algorithms to speed up or simplify generation of the images, improve the quality, the noise, the images? So this is just the base data generation, essentially. At a higher level, of course, this is the more traditional image processing problem. Well, now you have the data, you have to understand what's inside. So measure, quantify. So of course, the challenge here is producing semantics out of the data, And the way algorithms can help is by making measurements and quantification more robust, automated, and reproducible. At the higher level of data consumption is a patient-centric view that Steve and others also presented earlier today, which is now you have different sources of data, you have semantics on top of them, and the challenge is understanding how do they represent the subject, what is the state of the subject, what could be the trajectory, the evolution of the subject in the disease space or in the health space. And that's where the challenge is how to integrate the data to get potentially predictive answers. And in more general sense, this is where we introduce the concept of the digital twin. Even higher level, of course, it's where you look at patient cohorts, patient populations, and there the challenge is how to optimize the delivery of care across systems, healthcare systems. But I will not really deal with this in this presentation. The main goal, essentially, that for which we are, where we are positioning our technology, is trying to find methods to do the right thing for the right patients at the right time, which is essentially means try to make the workflows more efficient, reduce errors, select what is necessary and what is not necessary, avoid unnecessary interventions, and when you know what should be done, you still have the option, the opportunity of doing precision medicine, so what is really best for the specific patient. And now I will just give you a few examples of technology that we developed. These are more on the data generation side. One of the technology that we have currently available is combining an additional sensor on top of the medical diagnostic imaging scanner. So this is a 3D camera that allows automatic detection of the sizing and the orientation of the patients on the table, with the goal of optimizing those delivery for optimal imaging of different body parts, and also, of course, allowing streamlined workflow and simplified workflow. And of course, the natural extension of this is making it as a tool that can actually take over some of the workflow steps. So in this case, similar concept. A camera scans the body of the patient, generates an avatar of the patient's landmarks are automatically detected, and now the workflow becomes: I want to scan the knee, I want to scan the hip, I want to scan the shoulder, and the X-ray tube positions automatically based on the detected landmarks. On the second layer that we discussed, quantification. So this is an example of technology that we introduced a few years ago, which is automatic quantification of valves from 3D transesophageal echo. This was released together with our new TEE probe that combines the acquisition of a stream of B-mode images together with Doppler, and that allows you essentially to do anatomical quantification as well as functional quantification with potentially estimation of insufficiency or stenosis, and was coupled with machine learning based solution for automatic detection of the annulus and also automatic generation of anatomical model that can be tracked over time. And you see an example of measurements that are automatically generated by the system. And again, next step is actually bringing this technology where it's used, where it will be useful for guiding the interventions. We have similar solutions based also on CT images, and the challenge is always how do you register it back to the angio system. In this case, the solution that we are working on is based on the automatic detection of the position of the TE probe in angiographic images, as well as the identification of the 3D pose. And the system is actually also trained using deep learning in a supervised way to detect and recognize the position and orientation in space of the probe based on 2D projections. Once you have that, you can reproduce the position in space of the cone of the ultrasound probe, and then you can bring into the same context landmarks or the anatomical model that you have generated on diagnostic images. This, of course, is based on technology development that we apply to different different clinical problems. In the interest of time, I will not go into details, but we can have offline discussions. We have been exploring different technology solutions tailored to different problems, essentially. For body marker detection, a solution that proved very effective was based on reinforcement learning, where the agent was trained in a supervised way to find the optimal path from the center of the image to the landmark, to the landmark to be detected, essentially, combined with a multi-scale approach, where working on different upsampling and subsampling of the image, the agent is able to consider context that is farther away or closer to the object of interest. And then image-to-image networks for organ contouring. This is essentially a topic of multi-detection, where you have a CT scan, you want to detect everything that is in the scan. Tissue characterization, this is actually interesting for instance, in the prostate, for prostate cancer identification and grading. You have actually an intrinsically multi-source problem, multi-modality problem, and you want to be able to characterize the tissue property based on the different sources of the different formats of the data. And image registration, of course, to be able to bring different objects to the same context. I want to show you just one example on the cardiac analysis, and this is one example of image-to-image segmentation. It's a deep network that we trained on a large database of annotated examples. You see here, it's an interesting representation, essentially. You see the image that comes in and how the different layers of the neural network activate, and essentially at the end you can spot what is the task: blood pool identification, myocardium identification. So this is essentially just to give you a little bit of a visual sense of what's happening, how the parameters of the network are actually tuned to obtain the objects of interest in the output layer. And this we apply to automatic tracing of the contours of the chambers, but we also have solutions that, based on these, have automatic strain quantification from circumferential strain quantification from short axis views. And this was done in collaboration with the UK Biobank. Now let's go back. So now if we climb one step further in the ladder and we go to the prescription, the topic of prescription, what if we could have a digital twin of the patient's heart? I will borrow some of the arguments that Steve also used, but the way we define it is a multi-scale personalized physiological model of the patient's heart. So the idea is to have, I will say this is an practical implementation of the concept of the digital twin for the analysis of one organ. The idea is that the digital twin should have same anatomical features, same behavior, same physical behavior in terms of electrophysiology, electromechanics where needed. And this should allow you to have some more insights about the state of the organ. And also, it's a mechanistic model, so it will be able to show you how the model reacts to different loading conditions or different solicitations, different stimulations. The specific example that I'm going to consider is the use of this digital twin for support of cardiac resynchronization therapy. Just briefly, I know most of you are familiar with this, but the disease of the reference disease is the synchronous heart failure, and what you want to do is to recover synchronous contraction of the chambers, and the therapy of choice is the implantation of advanced pacemaker that is programmed to deliver electrical stimuli to the chamber. If you manage to program the device correctly, then you have recovery of synchronous contraction, potential recovery of heart function, as well as recovery and essentially it's improving of the condition of the patients over time. There are several challenges associated with this therapy. It's of course a challenging therapy in itself, takes time, and it's risky. It also has a significant number of non-responders, meaning that you may end up observing the patients down the line with no significant improvements in heart function. So the challenges are how do you identify the patients that potentially benefit from the treatment, and how do you deliver it optimally? How do you make sure that what you do is really useful for the patient? In terms of a couple of the parameters that can be optimized are the position of the leads and the programming of the stimulation. The pipeline to create a digital twin for this purpose is a standard patient-specific computational modeling pipeline. So I will not spend too much time, again borrowing from what we discussed earlier today. I would just want to mention that, of course, we saw how data-driven models can help in automatically and robustly generating an anatomical model. In this case, we will just focus on biventricular anatomical models for the use for CRT. Registration or fusion to bring information from, for instance, in this case, the light enhancement MRI on the state of the substrate, presence of the diffuse fibrosis or scar in the same frame of reference as the anatomical model. So in this case, digital twin, if you can see it as a simple example to register two different data sources. Myocardium fibers, as we discussed, that's also associated with a lot of uncertainty. Typical approach is used rule-based models, if available, which is not really readily available. Diffusion tensor MRI can provide some further constraints to define the architecture of the fibers. And then bringing in additional sensor data, 12 lead ECG or body surface potentials. Now the topic becomes how do you optimally estimate the model parameters so that the electrical activity of the heart, of the virtual heart, matches what is measured in the patient. And here we also explored reinforcement learning-based techniques to speed up the estimation of the parameters. And patient-specific cardiac electromechanics with the goal of estimating the stiffness and the contraction strength of the heart. Again, to be able to optimally match the motion that you observe in the images and pressure measurements when available. I just want to mention one potential use case of the digital twin that we tested actually in the field at University Hospital Bordeaux with Dr. Ritter and Dr. Lafitte, where we took the challenge to bring the digital twin where it will be actually used, so inside the cath lab. So the workflow in this case was the day before the intervention, we had the pipeline that I just described, essentially, processing pre-op diagnostic images for generation of the anatomical model, quantification of the scar, and use of 12 lead ECG to personalize the model. This is standard patient-specific computational modeling pipeline. So one level of uncertainty now, you have scar images, but you don't know how much of the tissue is actually viable, how much residual conductivity is in the tissue. And even talking with the clinician, it was not clear what hypothesis should be made. So we ended up designing two different digital twins. So in one case, a patch of the free wall was completely blocking. Second digital twin had residual conductivity. So you enter the cath lab with some uncertainty. However, in the cath lab, you have a new set of data that come here. The ECG is newly measured. For this subject, the ECG features, the ECG morphology was slightly different from what we had the day before, so we could re-personalize the model, update the parameters of the model. And the other thing is, as you implant the CRT device, the leads of the CRT device are now acting as a sensing device for you, so you can measure the intrinsic delay of the propagation of the wave from the right to the left. And now only one of the two digital twins could reproduce that time, that activation time that was measured in the patient. So that removed one of the. Of course, there are many other challenges, right? And uncertainties are all along the pipeline. But assuming that we accept the pipeline and you get to this point, then adding observation on the system can help you select what should be the model to be used. So with the new personalized model and incorporating new data, we were then just side by side reproducing the pacing protocol that was executed on the patient, testing stimulation, biventricular stimulation with the left ventricular lead in different positions, and checking if the reduction in the QRS duration was matching what was observed, which was the case. This is really just one case, so we cannot really extrapolate, but the point that I wanted to make is there is some uncertainty that we can remove if we have the luxury of adding observation to the system, incorporating data or knowledge that is oftentimes available to the hands of at the hands of the clinicians. So where do we move from here? Of course, the vision is to have a digital twin that evolves with the patients, it's lifelong, is updated, can integrate data at different observation points and time, and in the background you have AI systems, data-driven algorithms or algorithms, physiological algorithms that analyze the wealth of data and tell you, is this a normal patient? Is the patient maintaining a normal trajectory? Is there something that we should do? Of course, this is a long-term vision. There are many challenges to be faced and a lot of uncertainties, of course, as we discussed, but I'm sure it's going to be a very exciting journey. So that's it from my side. Thank you all.
Questions?
Yeah, I want to ask one question. Like several years ago, I was in Göttingen at institute which developed an MRI technique, and they were showing me some parallel acquisition of MRI signal that you can really see part without data. Is it like underway, such machines underway?
So we have one of the newest updates on the MR sensing side is what we call the compressed sensing, which is essentially using a smart sampling of the data, of the raw data that you acquire from the scanner, to allow you faster acquisitions, which essentially means that you can get CNS sequences in the order of seconds now. So that's one way to address that challenge, yes.
How long does it take to update a digital twin?
So this could be done in a few minutes, but it was using a simplified iconal model for the electrophysiology propagation.
You can't do it in real time. I mean, as continuously update as long as you are doing a procedure.
So yes, that's a good point. So right now, the prototype that I showed you was to be run interactively. So if you have new data that come in, you set them, and you have to repersonalize. So it's an optimization loop that will take, depending on the laptop, it will take a few seconds or 1 minute. So it's still interactive time. And then, of course, you can design data-driven approaches also for that. One simple example is, as you know, if you know how your model behaves, you can at least guesstimate what would be the optimal starting value for the parameters to speed up the further search, to make it even faster.
Very, very nice work. In your results, you're presenting back to the clinician, and you were saying that you're generating a lot of possibilities and then narrowing them down. Are you investigating ways that you can do that feedback sort of statistically, or what feedback would you give the clinician about the range of possibilities and which ones are more probable than others?
That's a very good point, and it turns out it critically depends on the clinical workflow, which is sometimes also physician dependent. So the kind of information that you present and the kind of feedback that you get is case dependent. In this case, in fact, we were able to discuss our initial guesses for the digital twins beforehand, and the clinician was giving us feedbacks based on his own intuition, saying, yeah, I'm guessing this is the right way to go, you should try this and that. So what I'm trying to say is that right now the interaction of the physicians with this kind of models is still a little bit unstructured, right? So we don't really have a structured way to capture it yet. So we are at the stage where we want to evaluate and try to bring the technology closer to the user to see exactly how they would interact with it.
Well, thank you very much.
Thank you.